have experiences. We'll have experiences from counties, some of our teachers teaching us. So I want to do a quick round of introduction. George, kindly mute your mic. George, kindly mute your mic. So I'll start from Mbagathi. I'll start with Dr. Witi. Unmute your mic, say hi to us. We are confirming that your mic is working.
Hello, Dr. Witi.
Thank you. Thank you so much. From Mbagathi also, Dr. Ngila Doris. We can't hear you, Doris. Okay, from Turkana County, Dr. Job Okemo. Job, unmute your mic.
Good morning.
Okay. Good. Machakos County, Dr. Ngami.
Good morning.
Perfect. Kisumu County, Neto. Neto, Dr. Neto, unmute your mic kindly. Okay, Kilifi County, June. June, unmute your mic, say hi to us.
Good morning.
Perfect. MTRH, Daisy Korir.
Nothing. Good morning.
It's okay. You're good?
Dr. Muya and your team, Kericho County. Dr. Muya.
Oh, it's okay. You know, I have Bluetooth. Eh? Okay. I have no problem, but I'm wondering.
Dr. Muya, kindly mute your mic. Kindly mute your mic. Kindly. Thank you. Dr. Kioma.
Good morning, everyone.
Perfect. Dr. Mogera.
Good morning.
Perfect. Dr. Marybeth.
Good morning. Good morning, everybody.
Dr. Nduku Kilanzo.
Good morning. Good morning, everybody. Thank you.
Thank you so much. And our boss, Dr. Lois.
To my video. Oh, I can't start my video. Good morning, everyone. Good to see you today. We have an interesting and very exciting session today. So we will start off with a case presentation, actually 2 case presentations, and it's really just to help us think around how best patients could have been oxygenated or how respiratory status of patients could have been managed. So we'll have one presentation from KNH Mbagathi and another presentation from MTRH. We'll discuss some of the management aspects together with Dr. Mugera, who will talk about some of the, oxygenation issues for these patients. After that, we'll have a presentation by Dr. Kioma looking at really advanced oxygen delivery. How do we use NRM? How do we use NIV, high flow nasal cannula? What are some of the things we need to watch out for in patients who are on higher flows of oxygen? Subsequently, we'll just get to know what is happening in the counties as relates to oxygen. And eventually, Dr. Nduku will tell us about some of the plans for boosting or improving oxygen issues in the counties. So you're all welcome. Dr. George, if you could kindly mute your microphone. Tamuya?
Me? Oh, okay, fine.
Oh, thank you very much. So Dr. Witi, if you're ready, kindly share your screen and you can go ahead.
Okay. I think I'm having a problem. I can't share it with my phone. I'm having a problem. I can't share it with my phone. Oh, yeah.
I have shared for you, Dr. Witty, so you can go ahead and present. I will just tell me when you need me to progress.
Okay, thank you. So Dr. Witty, I'm one of the medical officers working at the IDU CCU. Yeah, so can start on the case. So it was a 29-year-old lady who was admitted on the 7th of July and was discharged on 15th. Date of death was on the 15th of July, same year, 2021. Hospital duration was 8 days. She was a nurse working at the Embu Level 5 hospital. Next. So her presenting complaints, she had been having this cough that was on and off for about a week, which was followed by difficulty in breathing and general body malaise. Next. So she came in as a referral from Embu Teaching and Referral Hospital for respiratory support because she had this increased demand for oxygen. She had been on an NRM at 15 liters for about 3 days, and her SpO2s had started dropping down. By the day she was being referred, SATs were at 85. She was a para 1+0 gravida 2 lady with one previous scar who presented at a gestation of 33 weeks. Her COVID diagnosis had been made on the 28th of June, 2021. From Embu, she had already received her first dose of tocilizumab 400, had gotten some antibiotics, ceftazidime and mero, and also had been given dexamethasone 12 milligram start, then 4 milligram for 4 days for lung maturation of her baby, and she was getting oxygen support via the NRM. Next. So yeah, she had the antigen test, which was positive, had also gotten an obstetric scan, which had shown a single intrauterine pregnancy, which was of variable life. There was no noted COVID vaccinations that she had gotten. Next. On admission, on examination, she was in moderate respiratory distress with difficulty in breathing and was desaturating on the NRM that we had put her all the way into the 80s. Her SATs were in the 80s. She had this cough that was on and off, though was subsiding from what she was saying. Had some moderate chest pain, more towards the right than left, had a runny nose. Yeah, no pallor, no jaundice wasting or cyanosis was noted. Next. On the systemic examination, her airway was patent, was able to speak in complete sentences. Her breathing, she was a bit tachypnic with a respiratory rate of 38 breaths per minute. Her SpO2 was 80% on NRM at 15 liters. So that's where we made a decision to put her on high flow nasal cannula and plus NRM, and her SATs improved to 94. Circulatory wise, she had warm extremities with good pulses, which were regular and of good volume. The heart was okay. Her BPs were at 141/90 with a MAP of 105 and a heart rate of 120, which was a bit high. Disability wise, she was alert, oriented in time, place and person with a GCS of 15. For abdomen, we noted she was gravid with a fundal height of 34, longitudinal lie, cephalic presentation with a descent of 5 out of 5. Fetal heart rate was also present at 148. Next. So her hemogram, her WBCs were markedly elevated at 18.4 with a neutrophil count of 15.46. Monocytes were also elevated. Her HB was at 14.4 with a platelet count of 220K. Her biochemistry, the UECs were within normal ranges. in her LFTs, her LT, ST, GGT, and LP were noted to be all elevated, showing some signs of hepatic injury, together with a high D-dimer of 2.18. The blood gas that we had done initially after putting her on high flow, 2 hours post high flow, had shown that her oxygenation was still a bit low. Her PO2 was at 7.4, with a normal range being from 10. And also her SO2 was low at 87.5. The only imaging that we were able to do on her was an obstetric ultrasound due to her pregnancy, where her biophysical profile was at 8/8, with a single intrauterine pregnancy at 33 weeks. So management, we started her on oxygen therapy versus on the high flow nasal cannula plus NRM. The high flow was set at FiO2 of 100% with a flow rate of 45. And the NRM was at 15 liters per minute. She was for obstetric team review daily, encouraging her to lie on her lateral position. And also we did some incentive spirometry, assisted feeding, monitoring her vital signs, and also critical care team was on board for reviewing her. And we put her on full anticoagulation since she was bedridden, pregnant, and also had the COVID. So in the course of hospitalization, she was initially stable on the first 2 days on the high flow and NRM, though she was still having this tachypnea, but it was still way less than when she came in. She was doing all the way from 28 to 36. On the third day, it was noted that she was desaturating on the high flow into the 80s. So we decided to switch her to NIV. We put her on CPAP mode, and her SATs improved all the way to 92 to 95 during that day. We started her on an FiO2 of 100 with a PEEP of 7 and pressure support of 10. The obstetric team came and reviewed her on that day when she was desaturating. But when she had improved on the NIV, they deemed it was fit for her to have an elective CS when she was term. So on the 12th, she was now from mild distress into moderate distress. Her BG was showing a metabolic acidosis were now going down all to 68.9. So we made an urgent obstetrics review, had a discussion even with the HOD, and it was discussed to have an emergency CS to reduce the work of breathing. So the next day on 13th at 2 is when she went for her emergency CS, an outcome of a live female infant weighing 2.5 kgs. With a good APGAR score. And then she was brought back to the IDU CCU in some mild respiratory distress, put back on CPAP, but we had to increase the pressure support to 16, PEEP of 12, and her SpO2s picked up all to the way 90, and her distress became now mild from moderate. Next. So the next day, which was day 1 post the emergency CS, she started desaturating again while on the NIV. She was doing SpO2s of 86 to 88. By 6 p.m., she was now desaturating all the way into the 50s while on high settings on the NIV. So we consulted the CCU team and a decision to intubate was made. So we intubated her, and the patient was noted to be improving for the first 30 minutes. Then the SAT started dropping again, despite all interventions that we were able to do. So we noted the next of kin of the poor prognosis, then continued with her care. And by 15th, that was early morning at 1:45, with the desaturations into the 50s, she went into a cardiac arrest. CPR was commenced. We did about 3 cycles, but it was to no effect. So we certified the patient dead at around 2:30 a.m. So cause of death was hypoxia secondary to severe COVID-19.
Thank you. Okay, thank you very much, Doc, for that presentation. I think the reason we requested Dr. Witty to present this case is really as a learning point to see what are some of the things that could have been done differently, right from the time that the patient presented. How do we reduce morbidity and mortality in pregnancy? As many of you are aware, and as we've stated even in the previous webinars, we've recently noticed very severe outcomes in pregnant women. So we really have to think about how to manage certain populations when they come in. So I'll just make a few comments on the management, then I'll invite Dr. Mugera to also talk to us about a few of the issues around oxygenating this patient. So I think one of the saddest issues is that we have a healthcare worker who dies of COVID-19 and had not yet received vaccination. And I think this is really a call to all of us, to all healthcare workers, encourage everyone to get the vaccine. The vaccines, as we know, play a very significant role in reducing severe the need for hospitalization and mortality. So we really have to encourage all healthcare workers to get vaccinated. The second thing is around the early management. I think one of the things we mentioned previously is if you have COVID pneumonia, this is not a bacterial pneumonia, and we really have to think about use of antibiotics. We note that from the beginning, when the patient was seen in the other facility, the patient was put on ceftazidime and meropenem. These are both very broad spectrum antibiotics, which means if you start by giving a patient this, patients are going to be in ICU for long. Basically, what you're encouraging is selection of resistant organisms, so that when a patient does actually need antibiotics, maybe because they've gotten a ventilator-acquired pneumonia or other hospital-acquired infection, then your choices are limited. So let's really not use antibiotics unless you suspect that there's another infection that is bacterial. But purely for COVID, we do not have a role for antibiotics. I guess a few other difficult issues here. One is so that the patient had received tocilizumab. So we've talked about the role of tocilizumab previously. There may be some element of mortality reduction in patients who are deteriorating and are shown to have high inflammation. So in this context, you'd say if a patient has a C-reactive protein that is above 75 and is deteriorating, then there may be a role for tocilizumab. Many people who've used it before will tell you the outcomes are neither here nor there. They're not always the best. The other thing is that, remember, these drugs have emergency use authorization. We have very little data on pregnancy because, remember, for pregnancy, you're thinking both on the impact of the mother and on the unborn child. So where you want to use either because you're really pushed a wall and you're trying to use some of these drugs, you need to have a clear discussion with the parent, with the patient, and with the family to discuss with them those issues, and they need to give consent for use of those drugs. And this use really should be reported to the PPB, because if something goes wrong, then you really have nothing to support you about using it in a pregnant woman. So ensure it's explained to the patients, ensure the patients give a signed consent, or next of kin gives a signed consent if you indeed choose to use, remembering that we do not have data for pregnancy with some of these drugs. The patient was also given full anticoagulation. So remember, we said previously that in patients with severe COVID, you want to give them prophylactic anticoagulation. We do not have very good data for full anticoagulation. If you have a patient who's not pregnant, who is not doing well despite maximum management, and you think that pulmonary embolism may be an issue, then you can take that patient for CTPA. Of course, the challenge is in pregnancy and doing some of these scans. So in pregnancy, it's always a very difficult decision to make, and really consult with a specialist to make a decision based on all the other circumstances around the patient. So thank you. So Dr. Mugera, maybe just a few questions. Listening to this case and, from the time the patient came in, the transfer and the issues here, do you think there's something we would have done better in terms of ensuring this patient received sufficient oxygen?
Right, okay, I'm going to share the same slide and I'll just have a few comments on them. So give me a moment. Can you see my screen?
Yes, you've started sharing. Yes, we can see it.
Okay, so let me just go to the top. Sorry. Are you able to see it now?
Yes.
Better? Okay. So let's start with the presenting illness. She was at the Embu Referral Hospital, and our target of oxygenation by the time they should referred. In pregnancy, it's not 88 to 90, it's actually 92 to 94. That's our goal of therapy for the pregnant patient. So maybe there was a late referral at this point. We referred the patient at 85% on NRM, when our target should have been at 92 to 94 because she's pregnant. Then when she came to us, we started on high flow nasal cannula and the NRM. And yes, 94, she was at goal of therapy for a pregnant patient, but always look at the patient, not the number only. Remember, you have to wait 5 to 10 minutes to see what the respiratory rate is after the intervention that you've given. So we put the NRM plus the high flow. She did achieve our 92 to 94% saturation, but I would be interested to know what the respiratory rate is here. If her work of breathing, meaning her respiratory rate, had not gone down to about 30 or less, then we should have considered the next level of oxygen therapy, which is the NIV. So a learning is, don't put an intervention, yes, wait for a couple of minutes, repeat your blood pressure, repeat your respiratory rate, and see where you are. So at this point, that's something we should have done. Okay, from this blood gas, sorry, where's the blood gas? So from this blood gas, her PO2 was 7.4. So for again, the patient who's pregnant, we needed a better CO2. We needed a higher CO2. So you probably want 9, 10 on the PO2. And again, your saturation at least should be about 92%. So at this point, we should have considered the next intervention. If we were still on high flow nasal cannula plus the NRM, we should have then considered going up at this juncture. I think those are my comments. Of course, the patient, we went from NRM from the M hospital, we went to next level, which is the high flow nasal cannula plus the NRM. She was still having tachypnea. And at this point, when we're on high flow nasal cannula and NRM, we need to then consider the next level of care, which should have probably been NIV. So we may have considered starting NIV earlier, in view of the fact that she's pregnant and in view of the fact that her work of breathing was still high. So remember, numbers are good, but patient is the priority. So if your patient is uncomfortable, if your patient is still tachypnic and your guideline is 30, you want them less than 30 beats per minute respiratory rate, go to the next level of oxygen therapy. I think those are my comments.
Thank you very much, Dr. Mugera. Maybe just one comment before I ask another question is, in pregnancy, if you have a pregnant woman with severe disease who is not improving and requiring even increased levels of oxygen delivery, a patient who's deteriorating, that's not a patient you should wait on to deliver at term. Often ventilating such a patient is very difficult because, again, the diaphragm is all stented up, and it may be of benefit to really bring in the OBS-GYN team early and probably consider earlier delivery. So maybe the other question is, for such a patient, what are the things that determine when you make the decision to ventilate? Should we wait? Should we add high, nasal, NRM to the high flow? Should we ventilate earlier? How do you make that decision?
So the gold standard of making the decision is definitely your blood gas analysis. Embu may not have had the blood gas analysis to assist them. But then again, they are algorithms, just using your pulse oximeter, which I will share, and they can be used in the various counties when you move to the next level of care. So based on this case, they were doing 85% on an NRM. I suspect their goal of therapy was about 90, but for a pregnant person, it should be 92 to 94. So they likely needed to have moved to high flow earlier than they referred the patient to us. So that's one. So we have to know goal of therapy targets for non-pregnant and pregnant. Then we also have to know, if we can, and I'm encouraging that we get blood gas analysis machines. They are portable analysis machines, which can be in every county, and you will get your result within 15 or so minutes. If we are able to do that, which is the gold standard of deciding where we should be, it would be useful, because then we know that we either need to refer if we don't have an ICU, or we don't have the next level of oxygen therapy, or we need to move to the next level of oxygen therapy. Thank you.
Thank you very much. There's one comment, very useful comment by Dr. Lang. Because we are seeing such severe cases in pregnancy, it is important that pregnant women also get vaccinated. I know this has been a common question, and a lot of associations have come up to give some recommendations around pregnancy. And maybe Dr. Lang, I hope you're able to unmute yourself. I just wanted you to just make a very brief comment on your experience with ventilating pregnant women.
Thank you, Lois, for that. I happen to be attending 2 meetings at the same time, but that's fine. We are seeing a lot of these pregnant women coming in respiratory distress, and many times, if the gynecology, the obstetricians don't intervene early, they actually lose the babies. We get IUFDs. Now, it is very difficult to ventilate a distressed pregnant woman with pneumonia, as you have rightly said. And I think it is now becoming very clear to us that if there's a need to deliver the patient, the baby, one needs to move very quickly. Even now, as we are in this webinar, there's a case in Karatina where the lady is actually desaturating to points of almost 50%. And is requiring an immediate cesarean section. It's only going to be easier to ventilate this patient after doing that cesarean section. So we have even advised them to try regional anesthesia and deliver that baby as soon as possible. And soon after that, depending on the facilities they have, they may have to do early intubation. We are now beginning to see that if you leave these patients to desaturate to the point where they are doing saturations of 80s, even if they are not pregnant, if you wait for the time when they get into severe respiratory failure, type 2 respiratory failure, you may actually not be able to salvage them. So the ideal thing is to try and see with your gynecology colleague to expedite delivery of this patient. The ones who had been vaccinated, and not many were allowed to take the vaccine for some strange reason, the ones who have not been vaccinated tend to get very severe infection and they die. So the main thing is really to try and get the patient who is in severe respiratory distress, try and get the baby out if possible. And once the baby is out, then manage the patient aggressively. And the aggressive management of the patient, especially outside the bigger hostels, would be just to intubate that patient. Because when people try to give flows of oxygen of 15 liters, and the patient is still doing saturations of 80, assuming they don't have a blood gas analysis, those patients are actually being compromised because they are still hypoxic to some extent, and you need to aggressively ventilate them and minimize multiple organ failure. That is the reason why I'm actually very passionate about these pregnant women. And we are, even at the Nairobi Hospital, we have suggested that the obstetricians must be in the round. Even now at Nairobi Hospital, we have I think at least 3 patients, obstetric patients, who are being managed there. And luckily, we are now getting it right. So they are managing to do well. So let us try and see that we do not keep them for too long. And if they are in the peripheral centers where facilities are not adequate and the ventilation is not good as what we have seen in this patient from Embu, then refer them quickly so that we try and manage them in the best of centers. I think that's what I can say.
Thank you very much, Dr. Olang. I think we still need to keep advocating so much for better outcomes in pregnancy with this COVID, because you're going to see a lot of pregnancy related cases. Thank you very much for that case, Dr. Witi. I think it's generated a lot of exciting discussion and a lot of learning. Dr. Daisy, kindly go ahead and present your case.
Thank you.
Please put on slideshow.
All right. Can you hear me well?
Yeah. Okay.
Good morning, everybody. Thank you for the chance to present a case from.
You're breaking up a bit, but go ahead.
Yes. So, sorry. Thank you. I'll present a case from Moi Teaching and Referral Hospital, who has been in the unit now for at least 14 days. So this case, the 57-year-old male who was transferred in from the medical ward where he was being managed for new onset hyperglycemia, hypertension, and severe pneumonia. So the patient had presented there with vomiting for 1 week and cough, chest congestion, and difficulty in breathing for just 1 day. So he'd been placed on amlodipine 10 milligrams, HCTZ 25, and insulin 10 IUTDS, and also ceftriaxone 1 gram twice a day, and was on oxygen therapy via a simple mask while in the ward. So the saturations in the ward was at 15 liters per minute and was saturating at 78 to 80 with a respiratory rate of 34. And the random blood sugar done at that time was 9.9 millimoles per liter. So a decision to take a COVID sample was made, and the patient was transferred to isolation soon thereafter. So while in the isolation ward, a CT scan chest was done, which showed diffuse ill-defined ground glass opacities in both lungs, suggestive of a typical pneumonia, with a severity score of 15/25. So in the isolation, a trial of high-flow nasal cannula was made, but it was unsuccessful, and the patient continued to desaturate at 70 to 75 on maximum flows of FiO2 of 100 and flows of 60. PCR test came back and it was positive for SARS-CoV-2. And subsequently, this patient was now switched to CPAP with an FiO2 of 100 and pressure support of 10, and the saturations came up to 92%. He was also started on remdesivir 200 milligrams and then continued at 100 once a day. Was also started on IV dexamethasone 6 milligrams once a day, subcutaneous heparin 5,000 IU twice a day, esomeprazole 40 once a day, and the patient was continued on insulin for management of the sugars. So the labs that were done included a complete blood count where the white cell count was slightly elevated at 16 with a neutrophilia of 89.3%. HB and platelets were HB was normal, but platelets slightly reduced at 115. The patient also was noted to have AKI with a urea of 15.5 millimoles per liter, creatinines of 195 micromoles per liter with a normal sodium and a potassium of 5.26. A blood gas analysis done after placing the patient on CPAP showed that the pH was 7.3 and the PO2 was 42.2 with a PCO2 of 36.4. HbA1c was also done, which was at 6.9. The LDH was markedly elevated at 1,884, and uric acid had also been ordered, and it was at 582. D-dimers were also 4 times elevated at 2.02, and the CRP was also very elevated at 299 with a normal coagulation profile where the INR was 1. Troponins were also high at 48.78. So the patient was noted to improve on day 2 with mild respiratory distress and was still saturating at 95 on CPAP at settings of 100 and pressure support of 10. So the settings were maintained, and the patient was started on parenteral nutrition because it was difficult to feed while on CPAP because we are using a mask to ventilate the patient. On day 3, he was doing well and was still on the same setting, saturating at 96. And the plan was to reduce the FiO2 slightly to 90, the pressure support to 10, and he still continued to saturate at above 9. Before, the patient improved significantly. Saturations on the previous CPAP settings were at 95. So we continued to reduce the FiO2 to 80 and put on pressure support of 8. But the same night, the patient deteriorated. And so the settings were put up again to FiO2 of 100 and pressure support of 10 to maintain the SpO2s at above 90. So these were maintained on the following day. So on day 6, the patient was still having AKI, although the kidney functions were coming down. Urea was now at 17.5, creatinine of 178. So he was noted to be in distress and was also diaphoretic with saturations of 77 to 90. So at this point, a decision to try and give a little bit of IV fluids was made at 1.5 liters in 24 hours, and the saturations were being monitored. The patient still continued to desaturate at night, and so the FiO2 was put up to 100, pressure support of 14, and the saturations came back to above 90. The following day, this patient had now improved significantly, and so the FiO2 was reduced again, the pressure support was reduced, and his SATs were now very good at 97. So the plan was to reduce further to an FiO2 of 80 and pressure support of 10. The patient continued to have SATs of around 97, and FiO2 was continued to be reduced to 70, and the SATs were still at 95. This is now at day 9. On day 10, the AKI was still resolving. We had creatinines of now 125 down from the 178, and CRP had also come down from 299 to 125. His saturations were now at 96, 100 on CPAP with an FiO2 of 80. So the FiO2 was reduced again, 70, and he still saturated at around 95. So the settings were maintained on day 11, and on day 12, the patient was doing better, much better than before. And so the FiO2 was reduced all the way to 50 with pressure support of 6. And his saturations were at 94, pressures were okay. And also the fasting blood sugar never became a problem the entire time while on insulin 10 IUTDS. So this patient was de-escalated on day 12 to NRM at 15 liters per minute. And the saturations within the first hour were noted to be between 92 to 95. On day 13, was still on NRM doing well, but had developed these facial bruises on both cheeks, especially the left cheek from the CPAP mask. Saturations were at 97 on 15 liters, blood pressure was 147/96, and fasting blood sugar 6, pulse rate of 110. So the oxygen was reduced to 10 liters per minute, and lab works were repeated. So currently this patient is doing well on 8 to 10 liters per minute on NRM. SpO2s are 92, BP of 144/92, and fasting of 7. So the plan as of this day, which is now day 14 today, is to transfer to the general medical ward. And the current situation, basically in MTRH, is that we have about 16 patients on care, 2 of whom are intubated because they were not able to saturate well on CPAP. And then 4 are on CPAP, 1 on high flow nasal cannula, while 9 are on oxygen via either nasal prongs or NRM mask. So that is the case that we prepare to present. Maybe next time we try and present one whom we have intubated. Thank you very much.
Thank you very much, Dr. Daisy, for an excellent presentation. We're really glad that this patient is doing well. I'll just make one comment and maybe ask Dr. Mugera if she has anything to add on issues around ventilation. So one, we noted the patient was on ceftriaxone, so we'll ask, is there a bacterial infection? Remember, we have to do antibiotic stewardship. The other thing was the issue of remdesivir. We've talked about this in some of the previous webinars. So remdesivir has been shown to maybe reduce duration of hospital stay No study to date has shown impact on mortality. And most of the data is around its use in severely ill patients, not so much in critically ill patients. So if a patient has been around until now, they're going into ICU, it's already several days since the onset of disease, then they've entered an inflammatory phase rather than a viremic phase. And at that point, remdesivir may really not have a role. So it's really just thinking about the medication that we use. So Dr. Mugera, I don't know if you may have anything to add very briefly on the ventilation, then we can invite Dr. Okioma.
Okay, so my comments are one, again, we need proper goals of therapy. I noticed that the transfer to the IDU, the saturations were at 70 something on 15 liters of oxygen. So we have to know that our goal of therapy is actually 90%. So all our patients should be monitored regularly, at least every 4 to 6 hours, and see where we were so that we know how soon to start the oxygen therapy. That's my first comment. Then I'm very glad to see how you escalated and de-escalated the patient on the ventilation. That was fantastic. And then, of course, you also there are also dangers of using NIV, and we must take care of pressure sores, because a lot of our patients get pressure sores, especially for around the mask. So that's another thing that we must always consider. And the way to do that is always try and give them a break during your NIV, and at which point you should probably put them on high flow oxygen, allow them to brush their teeth, take a sip of water to help with the pressure care, area care. Thanks.
Thank you very much, Dr. Kioma, and thank you very much, Dr. Daisy, for really the excellent work that you're doing, even in management of this patient. So next, I'll invite Dr. Kioma to talk to us about issues NIV, high flow nasal cannula, when, how, what to look out for. Dr. Kioma, kindly go ahead and share your slides.
Okay, thank you very much. I'm presenting on.
Sorry, Dr. Okemwa, we called
Yes.
Dr. Okioma. Kindly
Okay,
down
okay.
the slide so that Dr. Okioma can present.
Okay, thank you.
We'll ask you to come a little later.
Okay.
Dr. Okioma, we can see your slides. Please go ahead. Dr. Okioma, yes.
I am on slideshow. You can view my screen, yeah?
Yes.
Thank you. Thank you very much, Royce. And I'm glad again to join this team during this presentation. We are going to discuss aspects of ventilation, probably in relation to the two case presentations that we have just gone through. And just to link up a bit. Sorry, my screen is stuck. Yes, just to recap briefly our initial discussion on oxygen delivery devices. We had wanted to look at how they work and when to use them. And of course, we looked at a few differences between flow rates, FiO2, and also which patients to use for different devices. We had classified these devices into two main groups, low flow devices and high flow devices. We're not going to discuss a lot on the non-rebreather mask, which is probably one of the most used devices with COVID. And this is because most of our patients require a lot of oxygen. Of course, with that, we know to escalate between 10 and 15 liters. I do know some people go beyond the 15 liters, but with that, you have lots of other concerns. And one of them is, unless humidified, then it causes a lot of drying of the airways. And also that air can be quite cold and also cause you other issues. In my view, once a patient gets above 15 liters of oxygen, which is equivalent almost to 100% FiO2, then you need to think about a different way or device to deliver oxygen to this patient. And this is where we mentioned the Venturi mask, which can generate a little PEEP, the high-flow nasal cannula, which also can generate a little PEEP, and the other two gadgets, which we don't use typically, but they can all generate some pressure that can aid in delivering oxygen to the patient. Other than that, with the gadgets we've mentioned, those are non-invasive, or that is not mechanical ventilation. These ones, or these gadgets we have discussed, depend on the patient's own respiratory drive. When a patient's own respiratory drive is compromised, this is a time now to think about mechanical ventilation. And mechanical ventilation, as we know, will generate either a pressure or a flow. And in most cases, of course, we are going to use ventilators. With the high-flow nasal cannula, it is not a pressure generating gadget, but it generates significant flows that can also give you between 2 and 5 centimeters of water in terms of PEEP, which can be quite useful. We'll discuss more about the high-flow nasal cannula. With invasive mechanical ventilation, which I'm not going to talk about, it's either through an endotracheal tube or through a tracheostomy. We are doing a lot of tracheostomies in our unit, and we have seen very good results, especially for those long-stay patients who have significant lung fibrosis, and also those who tend to get significant secondary infections, including secondary pneumonias, with the common bugs being Acinetobacter and Pseudomonas. Klebsiella is also common, and E. coli. Having said that, non-invasive ventilation has gained a lot of traction during this pandemic, and it is worth a mention because it requires less of capital investment, both in the counties and even in those specialized areas where COVID patients are being managed. And we are going to look more into what options do we have for non-invasive ventilation. We did mention during our first webinar about high-flow nasal cannulas. And until last year, until the onset of this pandemic, probably most of us did not know about the high-flow nasal cannulas. But we now have not only the knowledge about how they work, but experience as well in using them. We have a number of them in our unit, and they have been quite useful in several scenarios. The idea in terms of using the high-flow nasal cannula is, one, you're generating a higher flow, and then you're also going to deliver air or oxygen in a warm and humidified manner. And we know that is physiological, and that, of course, can theoretically be assumed to improve the delivery of oxygen. In terms of setting up the high-flow nasal cannula, I've noticed challenges in this. And people ask, at what flow do you start? How do you escalate? And which patient do you feel may or may not benefit from the high-flow nasal cannula? Usually we start between 30 to 35 liters, that is the flow. And this is going to be based on the patient's level of respiratory distress. After you review your patient 10 to 15 minutes after the start of the therapy, then you can increase sequentially to provide more support. Dr. Mugera did mention the need to continually assess a patient. Once you have had any intervention, you don't leave the patient and walk away. You have to reassess the effect of your intervention, and if need be, you intervene to achieve the desired goal. So that is the principle, the general principle. The more distress your patient is in, then the more flow they need. In terms of oxygenation, the idea is to adjust the FiO2 from 21 to 100%, And this is going to be achieved by using the flow meter on the wall, because that's where your oxygen source is. Do not delay intubation if required. And there are a few other aspects that you need to note. A patient who continues to have significant tachypnea, hypoxemia, and tachycardia and has increased work of breathing after maximizing the flow and the FiO2 needs to be intubated. And such patients tend to remain at very high flows of 60 liters per minute and FiO2s of 100%. You need to act with speed in such a situation. It is always wise to anticipate significant desaturation during intubation of any patient who has failed from high flow nasal cannula, and not just from high flow nasal cannula, but also from the other gadgets that we have talked about that are non-invasive. The winning procedure basically will follow the same kind of algorithm, where if a patient is having good saturations, then you tend to reduce the FiO2 more. And if the patient is having less and less work of breathing, then it is the flow that you look at for. So the flow tends to go with work of breathing, and the FiO2 tends to go with hypoxemia or saturation in that case. Having said that, we did speak about respiratory oxygenation index or respiratory rate oxygenation index, and this is used to predict the success or failure of high flow nasal cannula. And we did look at the formula last time, and we also did look at what are the cutoffs. If you have respiratory or what is called the ROX index of more than 4.88, 12 hours after initiating high flow nasal cannula therapy, then there's a very low risk that your patient is going to require escalation. If between 6 and 12 hours, you have this kind of respiratory rate oxygenation indices, then you are very highly likely going to have high flow nasal cannula failure. And in this case, you cannot do anything else other than determine or use a higher mode of oxygen delivery. So what are the indications? One, as I said earlier, we know that you generate very low PIPs, 2 to 5 centimeters. And in that, or due to that reason, high flow nasal cannula, an escalation from a non-rebreather mask or a Venturi mask in a hypoxic patient. So any hypoxic patient would be a candidate. But there are a few exclusions. And one of them is patients who have significant cardiogenic pulmonary edema, all have concomitant hypercapnia. They are not going to benefit from a high flow nasal cannula. We do know the humidification and the fact that this is warm air helps with secretion clearance. We'll mention this as we speak about the masks or the NIV masks. In summary, we are going to use the high flow nasal cannula in pneumonia in patients who have early ARDS. The other indication, of course, is post-extubation. We have been using the high flow nasal cannula to support patients who have successfully been extubated. And we have also seen quite some good results with that. The Frolari trial in 2015 probably was the first to bring to the fore the role of the high flow nasal cannula. And just to summarize is that the group that was treated with the high flow nasal cannula had a decrease in the 90-day mortality, which is a very key endpoint or outcome. What was not different though between the high flow nasal cannula face mark and NIV is the requirement for endotracheal intubation. There are a few studies you may come across that have looked at high flow nasal cannulas in relation to other modes of oxygen delivery and COVID-19. The editorial in JAMA was quite conclusive that it's the high time to consider using helmet. Sorry, this was meant to be for helmets, but the other two, sorry, I put that in the long slide. The Chinese study in May 2021 in regard to the use of non-invasive ventilation, the systematic review did look at high flow nasal cannula in relation to NIV, and there was a lot of support for the high flow nasal cannula. The last study was by Monil Shokri in Egypt, and they had 84.6% success rates in using high flow nasal cannula and non-invasive mechanical ventilation. So this is the hardware for the high flow nasal cannula. That is the flow generating gadget. The front part is the humidifier, and it has a hot plate that humidifies the distilled water that you hang with a bag, and it slowly trickles into the chamber. It has a one-way valve that ensures that there's a certain level of water for humidification within the gadget. This is usually a gadget-specific tube or circuit, which is connected to what is now the nasal cannula. The nasal cannula is from the point where my pointer is, and this also tends to be gadget-specific. Not many gadgets can share that. And just looking at it again here, the main issue is you have a gas blender that blends oxygen, and this is how you are able to control the FiO2 using the flow meter. And that is basically what the gas blender means. So the air goes through a humidifier. As I said, there's a hot plate that heats that distilled water, and as the air flows through that, it is humidified and warmed. These are just two pictures of two common high flow nasal cannula blanks. Let's now talk about non-invasive ventilation. And here we know we are going to have two interfaces. One is either a mask or a helmet. The other name for non-invasive ventilation is CPAP, but you should note that CPAP per se depends entirely on the patient's own respiratory drive, but there are many other forms of NIV. So CPAP is not equivalent to NIV. This is just a pictorial depiction of a patient on NIV with a mask. This is what we call oral nasal. It's covering the nose and the mouth. It's connected to the ventilator, and this is something we are going to discuss about later in terms of the interfaces and also the ventilators. The other option is the helmet, and this also has come to the fore because of COVID. And it's good to note the components of that helmet because it's quite important. There's the hood. There's what is called a patient access and suffocation port. In case the patient suffocates, you can open that. You have an inspiratory ring and an expiratory ring. You're able to pass in nasogastric tubes through ports on the ring. This is the neck ring. And there's a soft collar or seal, as we call it, which is usually silicone that is supposed to be fairly tight, not constricting, but tight on the neck. The straps are very important, and they pass under the arm to the back and to the front, and there is an anchorage of that helmet. These are the different types of the NIV masks. And for the purpose of managing COVID, the most important thing is, or the two important ones, is the nasal and the oral nasal, the ones that cover the nose and mouth, and then the nose alone. The one for the nose alone is used mostly for COPD and sleep apnea. And remember, most or a good number of our COVID patients may also have COPD as an underlying condition. So they can continue to use that. A number of them also do use angled mouthpieces for their ventilation. I've noted with a bit of concern that some safety valves are masked with tape during NIV, especially when you're using a single limb for ventilation, and that can actually lead to suffocation of your patient. This is just a summary of what we have gone through. I'll not belabor that. And this is also a pictorial depiction of the various interfaces and harnesses that can be used for NIV. I've mentioned the most important being the oronasal and the nasal interfaces, and of course, the helmet. These are just the goals of NIV. I'll not go into that. We have discussed this and we shall discuss this more with the invasive ventilation webinar. And the criteria for considering non-invasive ventilation is very important. Of course, with COVID specifically, then we are thinking about the work of breathing and also other assessments of breathing, hypoxia, hypoxemia, and also CO2 retention, if there is any. If a patient has copious secretions, has a high risk of aspiration, facial burns or trauma, or very uncooperative, they are hemodynamically unstable, then you need to really think about using a different modality, not NIV. This is just a summary of the ideal interfaces. What are you looking for to have an ideal interface? And this is for the really good purpose of one, being able to deliver adequate oxygenation, and then two, for the patient's comfort. And comfort, of course, will come with more compliance and more likely a success. There are a number of concerns with NIV that we must talk about. One is air leak, because without a good seal, then you're not going to be able to deliver good NIV ventilation. And to reduce that, these are some of the different methods that can be used. The most important is to use the correct or the proper interface in terms of type and the size, and you secure it properly. The other additions are just for those cases where you still are getting challenges. For example, using foam seals or hydrogel seals for improving the seal. The other issue is, of course, how do you reduce skin damage during non-invasive ventilation? We had a lot of this during the first weeks that we used NIV a lot. Most of our patients were getting a lot of ulcers at the nasal bridge. And we did notice that the main reason was the type of mask that we were using that did not have what we call a nasal forehead spacer, because this reduces the pressure on the bridge. Of course, using pads is very important, or using any other forms of cushion is important. Replacing the masks when they are worn out is also very, very important. The other issue, we are now going to the helmets, and the helmets as an interface, I've just shown three different types of helmets here. They are from different manufacturers, and the only difference is with where the ports are and where the straps are, where the accessory ports for NG tubes and all that are, but we have discussed the main components up there. So whichever brand of masks of helmet you get, the principles are the same. You just have to look at what is important for you. In terms of comparing the helmets and non-invasive ventilation, the helmets are becoming more and more appealing. And the reasons is one, there's less resistant to flow. It can be applied literally to anyone, although with facial trauma, you have to have precautions. It allows your patient to cough. There's less need for patient cooperation because they are more comfortable, and there's less interference with speech. The other issue, of course, we are able to still feed these patients. As I said, you are able to pass NG tubes and feed them. And the other advantage is you are also able to use the helmets without a ventilator, and we are going to look at that briefly. Of course, there are contraindications to using a helmet. Claustrophobia, very important, tetraplegia as well, because these are definitely going to affect your outcomes. Sorry, I think I mixed up those slides. This is the use of NIV with a helmet and without a ventilator with wall oxygen. This is the setup that ensures a one-way delivery of oxygen, and it's able to generate PIPs of up to 12. And as you see, one of the ports is blocked, and you are delivering oxygen through a single port that generates a PIP within the chamber. And this is how it looks eventually, and it's applied. This is just a demonstration. In most cases, it's the nurses and the doctors who apply the helmets. So that is the hood. This is the ring that fixes onto the lower part. And this is the seal that we spoke about that has to be measured to the patient's neck specifically. In terms of looking at the ventilators and modes to use for non-invasive ventilation, this is a very big topic. I don't think we can go through it within the timelines that we have, but it's important to know that there are many ventilator brands in the market, and most of the ventilators have an option for either invasive or non-invasive ventilation. Always change the modality to NIV if you are using NIV. There are situations where patients have been erroneously put on NIV, but they are actually on an invasive mode on the ventilator. Some ventilator brands may also not do invasive and are only able to do NIV, but majority are able to do both. In terms of the actual modes, there are many aspects to consider. I didn't mention that with CPAP, the patient is going to basically drive the breathing. So the only thing you apply is pressure in centimeters of water. And the CPAP per se is very good for patients with COPD and sleep apnea. What I have noted though with the COVID patients, they require a more invasive form of NIV. And in this case, they tend to require both PIP and a pressure support. And with that, there are different modes that you can pick. The easiest is of what is basically a BiPAP, and we do have also different depictions of these phenomena depending on the manufacturers. There are those that are called ST, and all that basically means you have a pressure support and the PIP. This, of course, the aspect of either being a pressure or a volume mode. COVID patients, in my view, do much better with pressure modes than with volume modes. And this is because their lungs tend to be quite stiff. So you have to look to determine the patient's lung mechanics. And in most cases, you have to try 2-3 different modes before you really pick out the one that best works for the patient. Additionally, you have to think about what is the pathology of the patients, and some of the ventilators, especially the portable ones, they are very specific to either obstructive, restrictive, normal or emphysematous pathological conditions. And each of these settings comes in with inbuilt kind of settings that optimize the patient's ventilation. To improve the success of NIV, there are several areas to look at. One of them is humidification, and we did mention that cold, high flow air can cause a lot of damage to the airways. And by doing humidification, you are literally mimicking the normal physiological ventilation, because the air we breathe is usually warm and humidified. Most ventilators come with provision for humidification. It's our duty to make sure that we incorporate the humidification and also to adjust the humidification to the patient's needs. Some patients need humidification more than others based on the secretions that they are producing. The other thing to think about also is humidification with helmet. That has been a challenge, and it's because they tend to mist a lot because of the air that is humid. And with that, in most cases, you need sort of a small release valve that makes sure there's no misting, and they tend to require lower levels of misting. Helmets do not cause as much drying of the airways as compared to the face masks. So these are just, this is just a pictorial depiction of some of the humidifiers. This is a small BiPAP ventilator that is very commonly used for NIV. This is the humidification that is to the right on the front. And the air that is going to come out through the circuit is going to be humidified. The hot plate is usually down there, and this is usually interchangeable. This is how the humidifier looks, and most of them can actually be used between different ventilator types, because those that do not come with a plate, or those that, most of the ventilators come with the hot plate, which is going to, or where the humidifier is going to sit, and it's going to be heated. The tube is, of course, what you connect to the fluid bag for the humidifying air. The other aspect is sedation and analgesia, and this is also very, very important in reducing the failure rates of NIV. This can be as high as 40%. And this can be because of mask intolerance, agitation, or delirium. If a patient on NIV or with acute hypoxemic respiratory failure fails NIV, then there's a very high chance that they are going to require intubation, and with intubation, the mortality is much, much higher. So what does sedation do? It decreases the patient's discomfort and agitation. And the aim is to look at sedatives that do not have significant effects on the respiratory drive, frequency, or the patient's hemodynamics. These are some of the options. One is the opioids, and morphine is probably the most commonly used. We should remember that opioids can depress the respiratory drive, should be used with a lot of caution. We know this also has an analgesic effect. There are other opioids that can be used, the fentanyls and the remifentanils, so we should remember that it's not just morphine. Ketamine is probably one of the most readily available. It has less effect on the respiratory drive. I know in the West it's not as commonly used as it's used in the low middle income countries. It's very readily available and affordable, and it's probably one of the most used. The idea is to optimize the dose so that your patient also does not become too deeply sedated. Dextromethorphan, although a bit expensive, is also very, very good. It gives what we call awake sedation or conscious sedation. And it's something that it's a drug that we can use quite often. Benzodiazepines, the most readily available is midazolam. Also be careful with that because it can have a lot of effect on the blood pressure and also cause significant bradycardia. Propofol, it's used especially for NIV, not common, but some people still do use it. It can cause hypotension and apnea, so it needs to be used in very controlled environments. The use of antipsychotics also should be considered, especially for patients who have significant ICU delirium. And in this case, it would be wise to consult experts, including psychiatrists, if available. Another way of optimizing NIV is to use what we call the Optiniv method. And with Optiniv, you are using the Optiflow, which is the high flow nasal cannula. That is the tube coming from the left. And then you're also using NIV. And based on what you need more, if you need more of the PEEP from the ventilator, then you can use less of FiO2 from that and deliver the oxygen more from the high flow nasal cannula. This has been shown also to improve oxygenation for patients, especially for those where intubation is really not a good option. This table compares NIV or CPAP with the high flow nasal cannula. I think we have mentioned all the issues here, but this is good for our reference as we will share these slides with you. And it is good that it mentioned especially the indications and the cautions. We use the high flow nasal cannula a lot for post-extubation with good results. And it's good to note that it improves the respiration of patients with thick secretions. This is because of the hydrating nature of the high flow nasal cannula. The use of NIV also after extubation is quite well studied, and there's a lot of evidence to support that. But you should also, or should always make sure that by the time your patient is being extubated, they are at the lowest possible settings on the ventilator, such that they can easily transition to a non-rebreather mask. But for one or two reasons, patients who have been ventilated for longer periods, they almost always require some NIV or high flow nasal cannula to support their breathing. It is not a failure to extubate a patient onto an NIV or a high flow nasal cannula. It's just a good way of de-escalating care. I think I'll stop at that and if you can take any questions from the audience.
Thank you very much, Dr. Kioma, for an excellent and very practical discussion. I think it's very practical for people who have high flow nasal cannula and NIV, and we're looking forward to having a session even on invasive ventilation and the things to look out for. So in the next phase of today's presentation, we're just going to hear from some of the counties what they have in terms of oxygen, how they monitor, what they can deliver. So to start us off, I will invite Dr. George Muya. Please go ahead, and for all the counties as agreed, just 2 minutes each, please. Dr. Muya, kindly go ahead. Who is coming after? Okay, as we try to get Dr. Muya, if Dr. Ngila is ready, you can go ahead. Okay. Dr. Ngila, are you there?
Yes, I am.
Okay, please go ahead.
Good morning, everyone. Thank you a lot, Dr. Joyce.
Dr. Loy, sorry. I am Dr. Angila. I am a medical officer at Mbagathi Hospital, currently working in isolation. And I am going to be presenting just what we have on oxygen sources and oxygen delivery devices. And mostly we are using the oxygen tanks that come in different sizes and capacities. And then we also have an oxygen concentrator. And on the oxygen delivery devices, mostly we are using the nasal prongs and the non-rebreather mask. And at this point, we really don't have the piped oxygen. And then we just have a few emergency airway devices. We have the Gardel airway, the iGel, the laryngeal mask airway, and the ET tubes. But at this point, we really don't have an ICU, so we're only using the non-rebreather mask. And then if you're not able to achieve our goals, then we're referring the patients from at that juncture. Next, please. Then on the oxygen monitoring devices, we have the handheld pulse oximeters, the monitors, and the moment we really don't have the blood gas analysis. Then on the point of human resource, we have, we have 2 critical care specialists. We have doctors, we have 3 physicians, and we have 6 medical officers. And at any particular point, we have 3 medical officers on the ground. We have 10 nurses, we have 5 nutritionists, 3 physiotherapists, 2 counselors, and 4 cleaners. Yeah, basically that is what we have at Mbagathi Hospital. Thank you very much.
Thank you very much, Dr. Ngila. As I invite the next person, I'll probably just ask you one question if Dr. Muya is ready. At any one point, how many patients are you able to give oxygen in the facility?
Okay, currently we are using the oxygen tanks. Sorry, I forgot to mention we have a 48 bed capacity. And depending on the number of oxygen tanks that are available, then that is the number of patients that we're able to give oxygen to.
Okay, thank you very much. Allow me to invite Dr. Nyawera. Oh, Dr. Mbati from Nyamira County.
I am online. I'll request Dr. Turanira to share my screen. Once again, from Nyamira County, we are trying our level best. Turanira, let's move to the next. Next. So yes. So in our facility, we've got an oxygen plant that was set up in 2018, July. That is the plant that has been supplying oxygen, both to the facility, which has a capacity of approximately 200 beds, but it also supplies the oxygen to the 175 facilities across the county. And there are other counties which once in a while come to tap the commodity from us. That includes Homabay County, sometimes Bomet and Kisii. The plant, as COVID started around 2019, towards the end, we did a pipe connection, especially to the ICU and to the COVID center. So, however, we also have cylinders which are also used in other wards. And therefore, due to the growing demand of this commodity, the county has already procured another plant which is being set up so that it can mitigate the increased use of this commodity. The next slide, please. I've listened carefully and watched on the screen of how the methods that are used in delivery of oxygen, but mainly in our facility, we only use the nasal prongs and and the oxygen masks. Those are the main ones that we use. And also there's that the invasive method of ventilation. Once in a while though, that has not been used so much. We monitor our patients using the pulse oximeters and bedside patient monitors that are available at the points of use. And in our facility, we have got 8 critical care nurses, 6 anesthetists, 2 doctors who are attached to the ICU, but we also have 2 physicians, 2 surgeons, and 2 pediatricians, and a gynecologist who also play a role, big role in managing our patients. However, we also have inadequacy. So the facility is doing a lot in doing on-job training. And it's good to note that one of our doctors is almost completing his anesthesia and critical care training, and he'll be joining us soon. So that is how far we are in terms of management of our patients. Thank you.
Thank you so much, Doc. It's really impressive the amount of oxygen that the county has, which is excellent. Allow me now to invite Dr. Wainaina from Nakuru County. Doc, please go ahead and share your slide.
Good morning. Good morning. Can you hear me?
Dr. Wainaina.
Yes.
Slides. Yes, and we can hear you. Please go ahead.
Okay, so my presentation on Nakuru Level 5 Hospital, our oxygen sources, we have oxygen tanks, which are filled at an oxygen plant owned by Hewatele. This plant is within the hospital, so it's a shared plant. So on the first picture, you can see tanks. These are attached to the pipes which run to the ward bedside. In preparation of the 4th wave, we have a small oxygen processing plant set up next to the isolation. That's the 3rd picture at the bottom. At the top, you have a regulator, which you can check. You can use to check the pressures of oxygen within the pipe system. For the oxygen delivery methods, we have first picture, we have nasal prongs, which we use for 0 to 4 liters. Second picture, we have the oxygen mask, which we use for 5 to 10 liters. Non-rebreather masks at the bottom, which we use for 10 to 15 liters. For more than 15 liters, we prefer using the helmet non-invasive ventilation. You can see the hood there and the shoulder straps. That's the 5th picture. And the final picture is one of the ventilators within the isolation area. For monitoring, we use pulse oximeters, bedside monitors, and the second picture is a picture of our blood gas analyzer, which we use for analyzing blood gas. In terms of human resources that are available, we have 1 physician and 3 anesthesiologists, 4 clinical officers, 17 nurses, 2 psychologists, 3 public health officers, 5 lab technologists, 5 support staff, and 1 from the records department. Thank you.
Thank you very much, Dr. Wainaina, for that presentation. I think Nakuru is one of the counties that has always been projected to have a high number of cases, and really increasing capacity even of the oxygen plant, or having high capacity of oxygen plants would be really good. Last week, we'd announced that, we had received, or we may be able to receive, some donations of high flow nasal cannula. So facilities that are in need of this, kindly let us know, and we'll see how to link you up with that. So allow me now to invite Dr. Ngami from Machakos County. Dr. Ngami, please go ahead and share your screen.
Thank you and welcome to this presentation. In Machakos, in Machakos, this is our current state. At the moment, we have 100 cases that are active. 38 of these are in the hospital and 62 are on home-based care. And that is our trend, daily trends of the cases as of 2nd of August. And it mirrors the national trends where we have going to the 4th wave. And the highest numbers recorded so far, we have 36 cases. Our capacity in the hospital, we've recently reopened our stadium isolation ward, which has a capacity of 100 cases. And so far we have 13 patients that have been admitted there. Our ICU bed, which has a capacity of 11, is now with 7 patients, and our ward 8 has 13 patients. Our sources, we have piped oxygen from our oxygen plants. And at this point, I need to mention that we have 2 oxygen plants in the hospital, and one is dedicated to the COVID ICU only. It has a capacity of about 250 liters per minute, and this has not been adequate. And this is where we have the greatest challenge, because at the moment we can't have more than 1 patient on CPAP, because every time we've tried to put more than 1 patient, we've had near-fatal experiences, or the other patients desaturate. The other sources of our oxygen include the cylinder and the concentrators, which are majorly in the ward and the stadium isolation. The piped oxygen is in the ICU only. We've been delivering this oxygen via the nasopranks, the face mask, and the non-rebreather masks. We've also been able to do CPAPs, but as I mentioned, you can only take 1 patient at a time for the CPAP. We're not able to do, at the moment, we are not doing any invasive ventilation because of poor outcomes. So the farthest we are going is CPAP. For monitoring, we are able to do the bedside pulse oximeters. As much as we have a point of care machine for the blood gas analysis, it's not in use currently because of the challenges of consumables. Our human resource include, we have 3 physicians who cut across the 3 units. We have 1 anesthetist who covers the hospital, but is always available to help in the management of our patients. We have 4 medical officers dedicated to manage the COVID patients in the 3 units, and 8 clinical officers, and a total of 3 nurses who are dedicated in the management of COVID patients. Thank you.
Thank you very much, Dr. Angela. Indeed, you point out a very pertinent issue that we see in many facilities where oxygen flows are low. So when you have 2 patients who require high flow nasal cannula, then they're able to sustain that. So again, really just the call to increase capacity for oxygen delivery. Thank you very much. I'll now invite Dr. Otieno from Lamu County.
Communicating with me.
Wait for Dr. Otieno. Dr. Muya, please go ahead.
Good morning, everyone.
Good morning, Dr. Otieno. Go ahead.
Good morning.
Good morning, Dr. Muya.
Good morning.
Dr. Otieno, my apologies. Kindly allow Dr. Muya to proceed because they have an issue they have to attend to. Dr. Muya, please go ahead.
I want to see our slides. So I'll do a quick presentation on what we have in our treatment center for COVID. I'm with Dr. Olympia, who is our ICU doctor, and I think she'll take us through the pictorial. Then I'll make 2-3 comments about the patients we've been seeing in the recent 2 weeks. So Olympia, you can go ahead. So to start us off, this is our oxygen plant, which has been in place for the last 3 years. it was serving us very well up to last year, December, when we had the last, well, when we had that peak last year towards the end of the year. Then it started to fail. It's still in use, but the oxygen purity is in question. Sometimes it can come as low as 70%. We're in the process of installing 2 new plants in the 2 main hospitals in the county. So as at now, we are relying a lot on oxygen cylinders. And the county is also in the process of procuring oxygen tank, which is being set up so that it can supplement supply from the cylinders, which we have to buy every day from Kisumu. In the picture, we have several equipment which is used in our isolation HDU ICU COVID. The first one is our regulators. Number 2, we have our CPAP face mask. We have monitor, and I don't know the last one. Of course, then in the middle we have, well, that's one of the rooms in isolation. Then the one, the last that we can have our piping. The next slide. Okay, I talked about this. This year, our demands for oxygen have been very high, and is the time the plant has been failing us, such that on a single day, we have to procure almost 50 cylinders of oxygen from Kisumu, so that we can sustain oxygen to our patients who are in the isolation ward. Next slide. We have several methods of monitoring our patients. We're able to do BGS. We also have monitors for our patients who need close monitoring. And we also have the digital pulse oximeters, which we use both in the wards and also in the isolation for the patients who need monitoring on a daily basis. Next one. Next. In terms of human resource, we have two specialists in intensive care, one in private and another one in public. The one in public is expatriate Cuban by the name Dr. Olympia Luis. She's the one who is in charge of the main facility in the country referral hospital. We've also had on-job training of medical officers who are coming handy in day-to-day running of our facility. We have around 12 ICU nurses who also assist in patient care, and also medical officers and also clinicians. Regarding the COVID situation now, we are seeing fewer patients, but who are very sick. And we've been able to do some genomic studies and typing. The main variant we are seeing is the Delta variant. And the first case which was presented about our pregnancy in COVID, we actually have a similar patient in our ward. I admitted her on Tuesday. She was desaturating to 70%, but today she's much better. She's doing 96% on oxygen. And she's around 30 weeks gestation, and we've just gotten the result of the the obstetric scan. The baby is viable despite a long period of desaturation, but she's faring well now. The other thing we've noted also, we have patients who have been fully vaccinated coming down with COVID. As we speak, we have 4. One is pretty sick because they have heart failure on top of COVID. The other 3 are stable. And as Dr. Lois mentioned, we still have healthcare workers who have not been vaccinated. I've seen 2 have come down with COVID in the last 2 weeks. And when we clock them, we realize they have not been vaccinated. So I think as we continue with this, we may need to come up with ways of making sure most of our care workers have been vaccinated. To the extent in the county, we've agreed if someone has not been vaccinated by 15th of September, if they become sick, you may just have to take care of yourself. I don't know whether it's a bit radical, but we feel that we may need to push people to get vaccinated because we know the vaccine is making a difference. Thank you. I think I'll stop there.
Thank you very much, Dr. Muya. A really excellent presentation on the current status. And you do make an important point about breakthrough infections in patients who've been vaccinated. We know these are rare. There's a very recent paper, I think it was just a preprint release a couple of days back, looking at the effectiveness of the AstraZeneca vaccine against the Delta variant, and it's somewhere just below 70%. So we know we may see a few breakthrough infections, but the hope is usually that these infections are not too severe and mortality is particularly reduced. So thank you very much, Dr. Muya and the Kericho team for continuing to do an excellent job. Dr. Otieno from Lamu County, please go ahead.
Good morning, everyone. From
what are you saying?
Lamu County, we have 2 isolation facilities currently. One is at the island, the other one in Peketoni. Our sources of oxygen remain to be considered.
We refer? Come.
Dr. Muya, please mute. Dr. Muya, please mute yourself. Go ahead, Dr. Otieno.
So we remain to be using concentrators for sources of oxygen, in addition to oxygen cylinders, which we have to source all the way from Mombasa. We still have a challenge in terms of being able to get adequate cylinders on time. We've had a bit of episodes where we totally run out of cylinders because they're being obtained on a first come, first served basis, and we do not have any priority. Our oxygen delivery methods, we use the nasal prongs and the non-rebreather masks. That's what is available for us at the moment. And in terms of monitoring of patients, we have bedside monitors and pulse oximeters, finger pulse oximeters. In terms of human resources, we are very lucky to have a physician intensivist who is working with us in collaboration with a local NGO as a volunteer. She's been with us for a couple of months now. We are probably going to have her for a few months until December. Other than that, we have just 2 medical officers in the isolation unit, and we have about 10 nurses, 3 laboratory technologists, and 2 casuals who are dedicated to handling of COVID. So we are really short-staffed in terms of human resources, and yeah, that's our current position. It would be nice to also have the high-flow nasal cannulas, but with the absence of an oxygen plant, we still have a long way to go. Thank you.
Thank you very much, Dr. Otieno. I even had to look at the distance between Lamu and Mombasa. 240 kilometers to refill cylinders is really hard. And I think we have Dr. Nduku with us here today. We appeal on behalf of Lamu that you receive some support to either get bulk oxygen or a plant. So thank you, Dr. Neto. We'll have one more from Kilifi County, after which we'll invite Dr. Nduku. Dr. June, please go ahead.
Okay, I'm Dr. June, a clinician working at the COVID isolation in Kilifi County. Current status, oxygen sources, we have oxygen cylinders. We are lucky to have an oxygen plant. Next slide. We also have oxygen concentrators. Next, please. Next. Yeah, as I was saying, we also have an oxygen plant. We have oxygen concentrators too, 2 currently. Oxygen delivery methods, we use the nasal prongs and also non-breathing face mask, as you can see demonstrated in the picture. Oxygen monitoring tools, we have bedside pulse oximeters and also the vitals monitors. Our ICU currently is ongoing finishing touches and will be functional by the end of August. Our bed capacity, generally we have 207 beds at the complex, but not functional right now. Isolation beds are 7 beds, holding area 8 beds. Oxygen points which are piped at the isolation area, we have 6 points. ICU beds are currently 10 beds, not functional yet until end of August. We are lucky to have 32 cylinders, 11.5 kgs, and 5 cylinders of 1.84 kilograms designated for ambulances only. Human resource, we are slightly understaffed because we have 2 medical officers, 1 clinician, 4 nurses, 1 nutritionist, 1 medical psychologist. As for the lab techs, we use the one designated for the facility. And also, yeah, we have four casuals, 4 who are designated for cleaning and yes, yeah. Thank you.
Thank you very much, John. I think we note that Mombasa many times has said they're receiving a lot of patients from Kilifi, and we can see why. We need the team to work harder to get a lot of things functional and to get you at least more than 6 oxygen points so you can, manage more sick patients. But thank you for telling us of your status. I think we'll also continue to appeal on your behalf for a little more support. Thank you very much. There are a few more counties that are to present today, but they'll do their presentations next week. The whole aim is to see what the county needs are and where we can support them. And now I want to invite Dr. Nduku Kilonzo, who's heading the Oxygen Committee at the National COVID-19 Task Force, to let us know where we are and what we can expect in the coming maybe weeks or months. Dr. Nduku, karibu sana. We can see your screen, but we can't hear you.
Can you hear me now?
Yes, we can.
Okay, thank you very much. And thank you very much.
Yes, Dr. Nduku, we can.
Thank you. Thank you very much for having invited me here. And I truly do appreciate the opportunity to be able to make this presentation. Unlike the other presentations that have been very technical in nature in terms of patient care, I am going to talk more about an overview of where we are at. Let me start by saying that the Oxygen Committee really was established as a result of some of the issues starting to think about oxygen last year from the COVID task force. And I think the key point to make here is that our primary goal is to work in collaboration with the counties to identify supplementary oxygen needs and mobilize resources towards these supplementary oxygen needs, because really the function, the mandate of delivery of oxygen, which is delivery of healthcare, remains with counties. So what we've been doing is actually mapping, working the council of governors, getting the status needs, being able to map and having action plans drawn up. These action plans have been fluid, changing. We have had like about 4 different sort of action reports that are based on an ongoing basis as we see different COVID situations in the country. I think the oxygen context has been discussed a lot here, but I want to start by saying that oxygen has historically never really been managed as a drug. Availability across the country was low. Priority was given only to critical care units, and in many places just simple oxygen not being available. As we are all aware, piping has never been a requirement. Piping for medical gases has never been a primary requirement, for instance, like when you're building a facility in the sense of having that as a primary standard that must be done. And I think moving forward, that is what is going to be happening. And then being able to monitor supply. We've never really had an information management system for oxygen. And through county support, all counties and treatment facilities have some source of oxygen. And I am really so impressed by just looking at what counties are doing and what they've been able to. However, we know we have had additional challenges. The key things we have learned from COVID, and I think I would just say one is the demand of oxygen. Yesterday, someone made a comment, and I thought when we were in primary school, we used to say, you know, the only free thing God has given us is oxygen. And now it is something that we have to buy, but not only buy, but really at high prices because it has increased all over the country. And then equipments are not there. Our PSAs, as someone, I think one of the presentations was that the capacity of production for the PSA is way below the saturation or concentration that is required. Backup systems, infrastructure, and cylinders. And I'll speak to this issue of cylinders because it is an issue that we are having to contend with in many ways. And then service contracts for PSAs are largely non-existent. And most of the spare parts are for import. We know very well, given COVID import, the supply chain, global supply chain on health commodities has really been adversely affected. And so that has created challenges with even just being able to maintain and increase the output and saturation of a lot of PSAs. The status of PSS is that the county assessment established that there was 64 PSS. Most of these were housed in referral hospitals. About 10 PSS have been established since last year, and piping is mostly available to critical care units. So having said all of that, what have been the recommendations? At least these are the March recommendations in terms of rethinking and reshaping our oxygen as a country. The first was surge oxygen. So supplement counties as may be needed, expanding distribution systems and introducing higher capacity oxygen plans. The second has been, sort of enhancing the capacity for rational use of oxygen. And part of these trainings that have been undertaken and continue to be undertaken on the series of oxygen are part of that increase of the rational capacity. Then there's been the question of strengthening the regulation of oxygen as a drug and enhance engagement with private sector. Let me just make a pause here on the issue of private sector. I think one of the things is cylinders are not enough. We know that currently most cylinders, actually if not all cylinders, the largest percentage belong to the private sector, meaning that they come with oxygen as we have procured from the private sector. This was never an issue before COVID, but now we are saying we certainly do need a pool of oxygen, of cylinders for medical gases that public hospitals can be able to access and need. And so a primary issue is a cylinder management framework that is being done in collaboration with the private sector. As you're very well aware, about some 3-4 months ago, the cabinet secretary made a very direct request, let's return cylinders back. So regardless of what we do, one of the big issues we are dealing with is cylinders. And then the supply chain, being able to get cylinders from anywhere across the world, even if you have money, because we don't always procure cylinders, then has also then created additional challenge. Produce cylinders has created additional challenges. So medical oxygen was listed as a drug in the essential medicines, Kenya Essential Medicines list. But into the future, in addition to being listed as a drug, it needs to be regulated as a drug. And I'll speak to that when I make some notes on what we have found about some of the policy gaps we have. So in terms of a status update, where are we? So far, there has been support that has been earmarked for about 390 facilities and installation and supply of liquid oxygen in 44 high volume facilities. Some of them, the contracts have already been done. They have already been drawing down from KEMSA, those that already have tanks that are sitting and established in place. I had the presentation from Bagathi. I know that Bagathi has been dedicated to get a tank. However, Again, importation, the tank has actually not arrived in the country, even though the contract was done more than a month and a half ago. Then we have installation of PSA plants with 3-year service level agreements that is targeted for 26 facilities. And I had the question around Lamu, so I quickly checked. And I think Lamu, if I am not wrong, there has already been some sort of assessment that has been done by the biomedical engineers around the installation of a PSA plant. And then installation of manifolds. As we know, one of the biggest issues is when you have one tank, one patient, we will continue to have the challenges around tanks for, as long as it takes. We need to be able to have more efficient delivery systems, and that can only be done through piping. So installation in piping is in 308 facilities, and I'll speak about the current status, and supply of oxygen splitters and basically just kits or oxygen support kits and accessories that are required, and some of them has been discussed at length today. So I was going to go through this slide, but I think it's important to kind of just give a sense of when we talk about being able to raise resources to provide this supplemental support to counties. It includes two things, two levels of support. One is the capital expenditure. When you talk about liquid oxygen, we are talking about a tank, piping, installation, delivery outlets. When you talk about cylinders or manifolds, you also have to do piping. When you talk about plants, you have to do power backup, piping infrastructure, and all of those have to be assessed by public works. Some have to be assessed by the biomedical engineering department. And so the works where it has already started, all that work has been done. And then there is then the question of ongoing operational expenditure, which is the day-to-day expenditure around management, services and repairs, that being a big one, and electricity, especially for the PSA plants. The other aspect is just as we have been thinking about what it is that we need to do and the technologies that are available. Obviously, as a country, we are currently, importing cryogenic, a lot of the cryogenic oxygen we are using, what is used in the bulk tanks. And so the question is, how do we become more sustainable? I think if there's anything COVID has taught us is that we must really become more sustainable. But I think the most immediate, which is sort of within the reach both of the counties, is the medical oxygen plants, the what we call PSA plants, or as are commonly referred. And it is part of what we are focusing on as we talk about these 26 facilities that have been targeted. And I think that targeting is informed by the data we get from counties. So the committee reviews the needs that are provided by COG. Actually, we are having an emergency meeting this afternoon because we have just received some requests from COG. So we review and we take action. So for instance, there was a recent reallocations of oxygen supplies in terms of cylinders based on need and request following the surge that was in Nyanza. And for counties with tanks, the current drawdown of almost 1 million liters of oxygen that has been procured stands not current actually. As of last week, Friday, stood at 273,000 liters of oxygen, because for the facilities that have tanks, they then just get refills based on a contract that was already done between the Ministry of Health and KEMSA. What is the other part of works that have been done so far? An additional 909 bed point terminals, that is piping 2-bed, is already been procured. The additional 1,200 is under review, and for these 534 have been complete. Some of them are done through partners, some of them are done through the ministry. And then for PSS of the 26, not 27, 27 have been identified for rehabilitation. 8 counties are identified as requiring new PSS of the PSS that have been supported. And so works are ongoing currently in 5 counties, and then assessments for BQs are ongoing ongoing in additional counties. And when I say counties, it may not tally with the figure for facilities, because you might find some counties have 1 or 2 facilities. Then we have obviously this training, sensitization, some training that has been supported through USAID. There have been a number of healthcare providers trained. I think for me, one of the big things is around the question of, as we think about into the future, the question of policy, and where we've been talking about regulation. We need to standardize PSA plans. They are so unstandard currently that even just the procurement of spare parts is a challenge. Saturation levels are differing in many ways. The packaging, should it be medical versus industrial cylinders? How should the manifold systems look like? So there's a technical working group that the ministry has set up that is looking at production, is looking at a distribution system, and is going to actually putting together standards for medical gas delivery within facilities, so that we have a standard that we can follow moving forward. So I want to stop there and say thank you very much for having given me this opportunity to just give you a sense of what the team is doing and how we try and ensure that we are supplementing and supporting where the needs and the gaps are. Asante sana, over back to you.
Thank you so much, Dr. Nduku. I think it's really reassuring to know that many of these plans are really at an advanced stage, and we look forward to a time when most of the facilities and counties will have sufficient oxygen. So I guess the question may be where facilities or counties have specific challenges and requests. Do they just follow the usual procedure? Is there a way they can send requests directly to the Oxygen Committee, or is this only done through this COG?
Thanks. To answer that, I would say that in order to ensure that we are standardized, we are harmonized, the facilities must make the request through the county, and so the county then makes the request through the COG. It's actually quite a seamless process now, because one of the things is that we made a request that each county appoints a focal point for oxygen, and most counties have been able to, and so that's why we are getting the requests much more in a harmonized way. Thank you.
Thank you so much, Dr. Nduku. And indeed, thank you to all the panelists. I think we've really had an excellent session today. There's been a lot of learning as well. We thank the counties for being open to share with us where they are, even as we continue to work together to ensure that, quality and capacity to manage patients is improved all around. So in view of the time, we will stop there for today, but we still continue with this oxygen series next week, which will be, I think, our last week of the oxygen series. So we invite you to join us then. So for today, thank you for joining. Goodbye and have an excellent weekend.
Goodbye, asante sana.
Bye-bye.